Welcome to Season 3 of Under the Sisterhood, Women Making the World Healthier. We'll be featuring a podcast every Friday through the end of the year. Our conversations will focus on many different aspects of health and wellness. We'll examine women's health, general health, menopause, sexual health, and reproductive health, as well as we'll dive into wellness. This is a podcast to celebrate women and all that they do in our world. I'm Elizabeth Elfenbein. Let's get under the hood. Today, we're getting under the hood with Dr. Emily Cunnings, a daughter, wife, serious cat mom, and a physician. As a third-year internal medicine resident at Temple University Hospital, Emily plans to start her career this June in hospital medicine. She calls herself a true Pennsylvanian, as she has been in all corners of the state. Born and raised in suburban Westchester, where she started her medical career as a pharmacy technician, to rural medicine, where she completed her medical school training at the Geisinger Commonwealth School of Medicine, now spends time in the hustle bustle of urban health at Temple University Hospital, treating a medically complex population in a safety net hospital. Emily hopes to offer a unique perspective on being a woman in medicine who is still in the training phase of her career. Welcome, Emily.
Hi, thank you so much for having me, Elizabeth. I'm so excited to be here. I hope that, sharing my story today can inspire some other, hopeful future physicians or nurses or anyone who identifies as a woman and wants to kind of pursue medicine, and just kind of go over what my experience was like, things that, were just wonderful for me, and just things that, you kind of have to get over and jump over those hurdles that come with just being, a woman in today's society. But would it change any of those hurdles or good things for anything? I really do love what I do.
Well, that's a great start. So I am, this is season 3, and it's all about women making the world healthier. And I think it's really interesting that we have the opportunity to speak to a new doctor. You're in your residency. In June, you'll be doing a hospital medicine doctor. If it's okay, I'd love to get started.
Okay, yeah, let's go. So where do you want to start?
Well, I want to start with, what was your inspiration? What was that moment, that inflection point that got you to think about medicine? Because you're at such an early stage, it'll be really curious to share that with the audience.
And that is a really great question. And I think a lot of people want to know, when was that aha moment? Was it like when you were watching Grey's Anatomy, or was it like an experience you had where you saw a doctor when you were a kid and you were like, wow, I want to be like my doctor? And I think the reality is that it's like the culmination of so many small moments that makes you realize that you want to do medicine. I think that growing up, I was very lucky that I found out early on what I wanted to do, because I had a lot of inspiring people in my life who were in healthcare, but also just a lot of women in my life who were in leadership roles. So I knew I wanted to do something big with my life. And then I also knew that I was taking like a particular interest in healthcare just because of some of the people that were around me. I think that, I have this moment to kind of reflect and honor some of these like incredible women in my life. My rabbi growing up was Rabbi Kravitz, and she was like pretty incredible, and she was a woman in leadership. And then I also was really involved in this art center as a kid. And a lot of the people who were directors at the art center were also women. So I just had like a lot of influential women throughout my life. And I think that's why I knew like I could be like a leader. And then from the medical side, I had many people in my family who were doctors, nurses, pharmacists, and I was, kind of drawn to what they did. And I think, of all the people in my life who were really inspirational from the healthcare side of things, was my grandfather. He was a surgeon. And he was an immigrant to this country, didn't speak a lick of English, and he went through medical school, and became a surgeon. And being an immigrant, I'm sure that was quite an experience. I'm sure he had quite a story himself. But I'll never forget when I first told him I wanted to be a doctor. He was like, in his accent, he was like, are you sure you want to do this? Like, it's really hard. Don't you want to have a family someday? You're never going to be with this and that. And maybe a little bit out of stubbornness, I kind of wanted to prove him like anyone can be a doctor. We all can do it. And especially women can go into medicine. And I think that being a woman in medicine has given me so many advantages, and just my relationship with my patients, the care that I deliver, the way I carry myself has been really something special. So that's kind of when lots of moments kind of led to me wanting to become a doctor. And
Wow.
maybe a couple episodes of Grey's Anatomy too thrown in there. But
That's
definitely the
great.
people in my life who were inspiring.
Well, first of all, thank you for sharing that. And that's just so beautiful. It's wonderful. You're so fortunate to have had so many women in leadership positions sort of lighting the way for you and showing you what you can have. And I think it's interesting. I'm just making the connection, being inspired by your grandfather being a doctor, or being motivated by his, like, hey, are you sure you don't want to go the more traditional route, becoming by the way, my father was a doctor, and he sort of, I never wanted to be a doctor, but he sort of said the same thing. You basically go have a family type of thing. But what I want to say, what I think is really remarkable about the leadership connected then to the medicine and science, is that that you connected the dots, that you can really, you can bring that leadership into medicine and science and make a real difference. And I love the fact that, Emily, that you connected to the way you treat your patients, the care that you provide. And I think women have a very unique perspective in that, one day we do become, a lot of us become mothers, and we have, even if we're not mothers, we tend to be the caretakers or caregivers of our family dynamics. And so we are rooted in that care. So I think that that's really, really amazing. So here you are. I mean, you went to college, you then went to med school. What was that experience like for you?
Yeah, I think that wanting to pursue medicine really starts early, like even pre-college in some ways. But in college, I kind of had to figure out what I wanted to do with my career. And the landscape into getting into medicine now is crazy. The amount of competition, the amount of classes that are like weed out classes that you need to get through just to prove that you're dedicated and motivated to do it, it's really intense. And I think there's a lot to be said and a lot to improve on how we approach medical education and the barriers that we put in front of people to just get into it. It's probably not the best way, because there's probably lots of people who'd be great physicians and end up being not able to ultimately pursue it just because of all these weed out classes that we have to go through, and financially the things you have to pay for to just kind of get from point A to point B. So in college, you have to really do a checklist of things just to even apply to get into medical education. So you do your classes, but you also have to volunteer and do research and job shadow so that you can really show whatever medical school you're applying to that you fit the bill, you've done all this work, and that you're going to be able to offer them something really special. It's really hard, and it gets even more intense. Like every year, the scores that you need, the amount of research that you need just keeps growing and growing exponentially. It becomes very hard.
Actually, if I may interject, it's really interesting that you're saying this, yet at the same time, it's really hard to get in. There's an issue with not enough doctors. So I'm hearing you say this and I'm thinking, well, that's just such a contradiction, because the amount of physicians, it seems like it's dwindling. I mean, do you have any perspectives on that?
Absolutely. So not only is it really hard to just get into medical school and to become a doctor, but there's not enough medical schools to actually make enough doctors to fill our needs. We don't have enough primary care doctors. We don't have enough specialists everywhere in medicine. There's not enough people, there's not enough members to just take care of our communities, which further worsens our healthcare disparities. And not only with the medical school, but even residency, there's not enough residency spots available for people to fill fill the needs of the doctors that our society needs to live healthy. And that's kind of in part the government too, not to get too political right now, but resident spots are actually funded by the government. So we rely on government funding to be paid. Like my salary is from the government. We depend on them to make the residency spots. So if they don't expand the residency spots, they don't approve for more slots, we're not gonna fix this problem. And it is not expanding fast enough to fill the needs of this nation.
Thank you. Thank you for that, Emily. And I apologize for interjecting, but I think that was a really good point because you're commenting on the fact that this is so difficult, so challenging, but yet we all know that that we're losing doctors by the minute. So it's really thank you for sharing that. That was very educational. So continue with your story. So you went into college, you had this checklist, and you were talking about the volunteering, all the things you have to do to be interesting and special enough for med school.
Yes, and I think the thing that helped me stand out the most was probably working as a pharmacy technician and really getting like an inside eye on what happens at a hospital. I got this job because I was getting my teeth cleaned and my dental hygienist worked at the hospital I ended up working at. And I told her I was pre-med and I really wanted to pursue some kind of career in healthcare. And I was kind of leaning towards, going into medicine and becoming a physician because I wanted to take on this great leadership role. And it just felt like it fit the most with my ideals. And she goes, literally she has like floss in between my two front teeth. She's like, oh, sweetie, I have this great job that you would love then. It's going to get you in. We have people who are pre-med and pre-pharmacy all the time working here. So the next thing I know, I'm working at this pharmacy. And I actually really loved it. It was hard work. And I think being a student and then working like nearly full time drove me crazy, but I loved every moment of it. And I think it's those experiences, like that real practical experience, that gave me an edge into getting into medical school. And I remember the program that I got into, the person who was interviewing me was most interested actually in that practical experience that I had, not like the hundreds of hours of volunteerism, not the research that I presented. It was the practical experience that I think interested my interviewer the most. And of course, this isn't a universal experience, but I'm really glad that, I did have that work experience because I think it helped me stand out a lot.
And that's a really, thank you for sharing that. But that pharmacy experience is a really unique angle to come in because usually, not that pharmacy can't be about prevention, but it's about treatment. So you're learning about, I would imagine you're learning about so much. What was that kind of like?
Yeah, so being a pharmacy technician, it's, you're working under a pharmacist and you kind of go around the hospital, you bring patients their medications, you learn a lot of the med names, the drug names, and you also like compound the IV medications that a lot of patients will need for their treatments, whether it be an antibiotic or an anti-epileptic. And I didn't think I realized the interface of like how that applied to my job as a physician until I really started residency. And you're running a code and there's a pharmacist outside the code room and they're compounding the epinephrine or the norepinephrine that you're going to be using in that code, or the amiodarone that you're going to be using because the patient's in a ventricular arrhythmia. So it was nice to kind of see the interface of what I used to do in college now is part of what I do now as a career, even if it's not like directly what I'm doing. It was kind of satisfying.
Yeah, and that's interesting in terms of I didn't connect the dots. You were working in a pharmacist situation within a hospital, which is even more unique as a physician because the interconnectivity. That's awesome. That is really unique. So, and a great opportunity to see things from that side, versus the physician side.
It's also funny to see the dynamics between like a pharmacist and the physician because they call each other over the phone. Sometimes, arguments will happen. Sometimes like good things happen too. Like they come to agreement on things, but it was definitely a great perspective. I love that job and I definitely think that I'm grateful. And another example of female leadership because one of the, or excuse me, I should say the director of our pharmacy was also a very strong and empowered woman. So all throughout my life, I've had a lot of great female leaders. And I think if there's like one theme that I have for this whole talk is, find the strong women, find the female leaders, because that's what's going to inspire you and get you places, and look for the role models that are like you. And wow, are we so lucky to be residents now where I can actually look towards female leaderships, because the whole landscape has changed over the last 50 years.
That's amazing. And thank you for sharing that. And I couldn't agree more. I mean, what a great time to just be in your career and figuring things out, whether it's a doctor or anything, because there's so many more women leaders in these positions. But in specific, I think it's really interesting in terms of healthcare. And I know my stepmother is a nephrologist at your university. And I know that when she was there, we were just talking about the numbers and the relationships of women, both in med school, then women at universities as both academic physicians and all of that. And the dynamic, finding these women leaders is so critical. So you're very fortunate. But what I love about what you said as well, Emily, is like looking for these role models, looking for the role models that will help support you, and in some ways kind of give you confidence and assurance that you can do it too, because you're seeing them do it. The ceilings are sort of broken down. So you go into med school, you've done your training as a pharmacist technician, you're doing your work, your undergrad, you go off into med school. How is that being a woman in that environment and the work itself?
Absolutely. So I went to medical school at the Geisinger Commonwealth School of Medicine. It was the first time I really kind of got out of my environment. I didn't really travel too far for college. Now I'm living in Scranton, Pennsylvania. I did training in Danville, some of the more remote areas, even outside of Danville, as well as Harrisburg, Pennsylvania, for my rotations. I think going through this training, the things that stood out to me as a woman, though, was figuring out what specialty I wanted to go into through this training. I knew right away I wanted to do internal medicine because I was very cerebral in my way of thinking. And I think hospital medicine, or part of it is outpatient as well in our training, but I now want to do more hospital focus. But at that time, there's also the outpatient side. It was just very cerebral and very doctor patient centered, because you're kind of that first line provider. You're the primary care, whether it's in the outpatient or inpatient setting, you're that face. And I knew that's what I wanted to do. I think as a woman in medicine, though, wanting to go into it, I think the hardest thing is that there still exists a little bit of implicit bias when you're evaluated. The words that are used when you're a female trainee versus a male trainee is different. So instead of using language that's like, for a man, it might be, oh, they were really innovative, they were really, cerebral, and they did this and this. As like a woman, a lot of my evaluation was, oh, she was really kind and thoughtful and sweet. She was really, patient and took time to do things. So you pick up on those subtle things during your training. And the other big part of training, which not wanting to go into a procedural specialty didn't affect me as much, but you still always get asked, well, when do you want to start a family? You get that asked all the time. Even within the medical school, you have advisors who are also going to ask you, when are you having kids? Do you realize how this is going to affect you having kids? And that's real. And you think that, people wouldn't ask you that. It's none of their business, but it still gets asked. So I would say what I've experienced the most as a woman trainee at medical school was just these implicit bias. And despite those barriers, still have to present yourself as someone who can be innovative, even though we're getting evaluated like we're just nice. So
That's got to be really frustrating. I'm frustrated just hearing that. In fact, I'm almost angry, but I meditate for the anger. But interestingly, Emily, I had a conversation with Dr. Huma Base, and she is based out of Beth Israel. She's in a residency. She's a surgical resident, and she shared some of the same biases. When are you going to have a family? Are you sure you want to become a surgeon? can you be a surgeon and have like, so, but I did not hear the bias of evaluation of, the male's the innovative, the woman's the kind, but has shared similar things. So this is, hearing it from you is just, wow. It's just like there's been a pause because it's been a year since I've interviewed her. So to hear this again is not so heartwarming, because women are both, the beauty is that you're both innovative and kind. You have empathy, which is really important. And speaking of empathy, did you have classes in your medical school training that taught you about empathy in terms of patients?
There's definitely more of a push towards patient-centered language and how we communicate with our patients. I think this is a newer part of medical training. We no longer are supposed to just see someone as, oh, they're a diabetic. It's someone who is with diabetes. It's a person that's afflicted by these things instead of seeing them as an illness. That's definitely been one of the bigger pushes towards medicine. And also just cultural competency and learning about diversity. I think you can't be a good doctor if you ignore the fact that people are experiencing things different than yourself. That's a huge part of cultural competency, and understanding that individuals, based on their backgrounds, based on what they have going on in their social determinants of health, might not be able to do the things that you would want them to do as a provider. And I think I experienced that a lot being at a safety net hospital, being at a hospital where we have very medically complex patients who don't have cars, don't have access to their healthcare resources, don't have high health literacy. It's really complicated. And it's not that patients don't want to do things to be well, it's that they aren't able to get the things to be well. And I think we also need to accept too that as healthcare providers, that there are some problems that no matter how much we want them to be fixed or better, that we're limited in how much we can really do. I think one of the most harrowing statistics I read was they did this study where it was like, how much do healthcare providers actually affect someone's overall health outcomes? And it's only like 20%. The 80% is like their social determinants of health. Like your zip code is going to have more impact on how long you live as opposed to like the doctor that you see. It's frustrating because we want to do everything for our patients, and we're like, all right, start a statin and you're never going to have an issue again. It just doesn't work like that. And I see that so much in my job every day.
Wow. Thank you for sharing that. And that's amazing. I love the articulation. I'm like so overwhelmed by that. There's so much to unpack there. I mean, wow. Wow. You have me speechless in a different kind of way, which is like, as I think about this, I feel like your generation of physicians, back to your comment around really understanding the diversity issues, the health equity, the social determinants, it's so much more complex because there's so many different, I don't know if it's psychosocial, so many different factors that have been made more aware of or have become, made more aware of. Like so that must have made your training even a little more complex because you're adding on all these cultural nuances and differences. And I think, just hearing you describe that, Emily, just makes me think, wow, you're pretty competent. You have a really good understanding of this. Is that something you feel? Because one of the things I would say that, my observations of certain doctors, and I think an internist is a good doctor because they have to have that empathy. They have to have that sort of gene that says, because they are the first person, your frontline doctor, right, who treats you. They have to want to get to know the whole of you so that they can treat you. But is that something, that you feel is pervasive in healthcare? And what I mean by that is, like, your generation is like more understanding of that, sort of past generations, maybe some of your professors, the cultural nuances, the things that you're more aware of today than say they were yesterday.
I think that there is a change from what previous generations used to think about when they took care of patients. It is a changing landscape. I think our training is shifting, but it's the cultural competency, it's how we chart and document things. The whole landscape of medicine is changing a lot from what it used to be. I like to think it's changing for the better, but there are some things that are getting harder for physicians to deal with. So we are starting to understand the social determinants of health and how they are affecting our patients more. But it's also putting a lot more burden on doctors, I think, too. And not even so much that puts the burdens on doctor. It's like the charting and the documenting, and there's so much more legal stuff now that's happening. It's definitely contributing a lot to physician burnout. We are moving towards a better direction, because even though we have to do more charting and this and that, and we have to do much more social work than I think previously, I think we're ultimately doing better for our patients. And I think that's the goal at the end of the day, is to do the most that we can for our patients.
I love that, Emily. That's really good. Talk about a little, you just slipped in. I don't think I didn't hear that. We're doing more social work. Talk about that piece of your job. That's really interesting that you added that.
Yeah, and we do have social workers. I don't want to like
No, no,
knock
no.
down them, because they are wonderful too.
No, I know that there are technically social workers
Yes,
there.
and
But
we are so grateful for them. But we have to become much more aware of what our social work does for our patients, more advocacy for them. For example, my patient comes in, and this is like the outpatient setting. This happens inpatient too, and they come in and they actually are wearing, their clothes are in in bad condition. You can tell that they're torn, they're not washed. They don't have any clothes to change into. So we have to go to the back room, and we have like extra supplies there that we end up giving to our patients. We end up providing, wound care supplies to our patients when they come into the office, which is more like case management and home care as opposed to social work. But I've definitely referred patients to rehabs and clinics for them to follow up with. I've become very aware of what mental and behavioral health resources are available for my patients, and I provide them with list of that. So even though, we're not doing as much coordination as our social workers are, we have to be much more aware of what resources exist. And then even at bedside, just doing a few little things here and there just to help them when they leave the hospital, to just hopefully prolong whatever they need a little bit longer, give them a couple more days of wound care before they can get into the clinic, because they're not going to be able to go to CVS and afford it for themselves. It matters too. So that I think is something I don't think I ever would have expected when I was just a medical student or a college student, that I would have to be involved in.
well, that's wow. Thank you for sharing that. And I think what's interesting to me about that is really putting the physicians. Now, you talk about your hospital as a safety net hospital, and I'll ask about that in a minute. But what I want to point out is that in the discussion of the safety net hospital, is as a physician, you're being put in the position to really see those unmet needs. And that's the way it sounds like that's the way I'm hearing that you're applying sort of those social workers. It's connecting them to resources, but it's more about seeing it. It's like, see something, say something, and you're saying something. And so you're making something happen. So, and you're right, before what physicians used to do their part of the job. And then, so I think that's interesting. So if you could, Emily, it would be great to hear your description and sort of your experience of being a physician in a safety net hospital.
Absolutely. And I think it's important to define what a safety net hospital is. So these are patients who don't have necessarily insurance, they don't have Medicare, Medicaid. So there's a chance that they come in here and they really have no way to pay for their health care. And it also usually implies that these are patients who are from lower socioeconomic status. They don't have access to great health care. They have multiple things that would affect their ability to get health care, whether it's food, electricity, transportation. These are our patients, the vast majority of them, I would say. So we're located in North Philadelphia. That's our patient population. So this is a population that has been really affected for decades by whether it be like redlining. I would say that redlining has affected their community ultimately, and many other really systemic causes of racism have affected these communities to kind of be what they are. And that healthcare is just one small facet of that. So these are patients who typically present very late in their disease illness. So we see things that really shouldn't even exist. Like I have seen full-blown HIV, like we have antiretrovirals now. People should not have CD4 counts of 10. We see very advanced heart failure that goes untreated. So patients go home. They aren't able to take the medication to preserve their heart function. So they end up coming in again and again with exacerbations. We have very severe asthma and allergies and COPD. We see a lot of substance abuse in our community. And unfortunately, we see addiction, which is itself an illness. And in addition to kind of our North Philly bubble and like the people who have lived there for generations, we also have kind of this new population too, which is our patients who are impacted by the opioid epidemic. So we cover the Kensington bubble, which if you're not a native to Philadelphia and you're listening to this, it's really I almost would say it's like the hub of the opioid epidemic. People come from California, Texas, Canada, other countries to get to Kensington to, use substances because it's so cheap there. I've had patients describe it to me as like the Amazon, like the company Amazon of the fentanyl, heroin use of the world. So that's another patient population that we have too. And it's hard. It's hard work. But that's our patients that we treat. And it is, as I said, it's hard, but every so often you'll really make a breakthrough with someone. You get someone to start cardiac rehab after their discharge. They come back to you. Their ejection fraction is better. They've gone and gotten some education, or maybe someone from the opioid side, they've started Suboxone and they're doing really successful on that. It kind of makes it worth it, but it's hard. And not everyone ends up being, a great success story. But you do it because you care and you enjoy the medicine.
Well, I'm sitting here thinking like, wow. I'm like, that sounds so hard. So you have to have all these feelings, being a doctor and dealing with this population and dealing with these challenges. How does that make you feel, Emily?
That's a great question. How do I feel about it? I think every day is a new day. And some days I think go really great and you have really good outcomes and care goes really well. And then you have days where you go home and you feel really frustrated. You try to understand why a patient may have left the hospital prior to finishing their treatment. You don't always understand, but you have to understand from the patient's perspective. They may have had some need. They may have lost their house if they didn't leave the hospital because they couldn't pay their rent. Maybe their children were home alone the whole week while they were in the hospital. It's frustrating when things like that happen, but it's also humbling when you realize like the reason a lot of these things are happening is usually because the patient needs to do these things that you would never in your wildest dreams have to take care of yourself.
I just give you so much credit. I have so much admiration and respect for the work you're doing. And just hearing you describe it, I mean, you are a young physician. And I mean that very respectfully. You're new in this world and you have a window in. You've picked one of the hardest places to work. And I'm not saying Temple University Hospital. I'm talking about the safety net hospital concept where you're in a community that has so many overlaying challenges. So I really think that's incredible. And I really admire that you're part of that. How, so you're finishing up and you're going to be starting your hospital. You're becoming a doctor in a hospital in, what was that, June or July?
June. Yeah, it's going to be here before I know it, but the process kind of starts now.
Oh, wow. And so what does that mean? And are you staying at Temple, by the way?
I would love to stay at Temple, but I'm applying to multiple places as I would encourage anyone who's doing this to do. I actually think of this one. He's one of my attendings. He's like, oh yeah, I only applied to one place. Don't do that. Although he's very happy where he is. You should definitely apply yourself and look diversely because you should see what other places have to offer. And it's sometimes good to get out of your comfort zone. Although I do really enjoy the type of work that I do at Temple, and would hope that whether it's Temple or somewhere else, it's a similar type of environment or population that I'm caring for. But it's the same thing again with being a woman in healthcare. You're going to get asked questions like, are you going to have a family? You're going to do this and this. And I think we need to just remind ourselves that if we're truly being feminist, then we should just do whatever we want to in life. It's kind of funny. I feel like the narrative now is like, oh, if you're a woman and you're a feminist, you have to do it all. You have to be a mom, you have to be a leader, you have to do the research and this and that and whatever. But you should just do whatever you want to do. And you don't need to have it all. You just need to do the things that make you happy and fulfilled. And I think that truly is what being a feminist is right now, especially as a woman in medicine. Just do the things that you love. But right now, the environment is still, you're going to probably get asked things about whether or not you want to start a family, this or that. And how much time you're going to need to take off work, and you're still going to get evaluated in the same way. But it's a changing environment. And I still think that we need to be proud as women to be in medicine. Fun thing about being a woman in medicine is we are starting to become the majority in medicine. So 53% of new medical school matriculants are now women. So we better be proud of what we do and continue to be leaders and find satisfaction and fulfillment in our work, whether it be you're, in an academic, research-heavy place, or you're just serving a community, just finding that fulfillment.
I couldn't agree more. And that's beautiful articulation. The thing I would say, Emily, is that your generation now, or maybe just a few years ahead of you, the women have the opportunity to rewrite those conversations or reframe those conversations. And so when they go in and they start asking the next generation of women coming into medical school or residency or whatever it is you're applying for, they don't say, when are you going to have a family? Of course you're going to have a family. This is how much we offer in terms of time off. We're going to give you this. Don't worry about it. That conversation has to change. And I think it's going to be up to women leaders like yourself, even at this young age, to have that dynamic when it comes to being evaluated against the male, saying, you know what, it's interesting. I hear them always describing the man as innovative. I'm not only innovative, I care, I give, I do all these other things too. So, I mean, I think that, and you'll get to that point. It might be in a year or two's time, or maybe sooner. But don't be afraid to have that voice, because you have that power. You're a doctor. You're a healer. You're doing amazing things for these communities, and you have every right to have that voice and to take that on. And even, I don't want to, I don't know what that means. I would imagine that they can't let you go for having a conversation like that. Imagine you were me to HR. Imagine you were me. I've just spent all this money going through med school, doing my residency, doing all these things, and I'm being asked when I'm going to have a family, so that just seems, it seems so backwards. And especially with the majority of women coming through and being matriculated as physicians, it doesn't make sense to me. But that will be your generation to start changing conversations. I think you're just extraordinary. I love this conversation, Emily. You have so much wisdom at such a young age. And I really love I feel like we've been in 4 dimensions, because you're dealing with so many different aspects of, you're looking at the whole person, the system, and the community in terms of care. This is your platform to give a message to women around the world, if you want to talk about women in medicine or women in general, but of all ages, of all backgrounds, of all cultures. What do you want to tell them, Emily?
I think that you can do as much or as little as you want. If you want to do it all, you can have it all. If you just want to do 1 or 2 things, just do your 1 or 2 things. And don't let anyone tell you that you can't do something. Just go for it. There's so many opportunities out there. As women, we can do it. We can really do whatever we want. We can have it all. I feel like that's much more simple than I wanted it to be, but I think that's what I would want to pass on. And
well, I still, you passed on so much. This is a tapestry of a conversation. So I think it's kind of nice to end on that high note, which is, You can have it. You can do as little or as much as you want. You can have it all. And I like the fact that you said that. It doesn't mean it won't be challenging. There won't be moments, as you said. There is no path that is straight. There's no path that is linear, and that's what makes life interesting. But I really, really value this conversation, and thank you so much for getting under the hood with us today, Emily. Dr. Emily Cunnings, thank you.
Yeah, thank you for having me, Elizabeth.
Thanks for listening to Under the Sisterhood. If you haven't already, please give us a quick rating and review on Apple or Spotify. And make sure to follow us on Instagram, Facebook, YouTube, and LinkedIn so you can hear from more amazing women. This podcast is created and hosted by Under the Sisterhood LLC and Elizabeth Elfenbein, produced by Elizabeth Elfenbein and Matt Butler, and edited by Matt Butler. The music is by Ayla Schaefer. Her song, Rose.